Hello, everyone. Welcome. We're gonna start it. This is a new link. Just join this one instead of the other one. Hello, everyone. Let's get started. Kindly use the chat box. I'm just gonna share the link one more time, as this is the new link. While I share the link, kindly maybe write your name or where you're from. That'd be great, wonderful, on the chat box. And if you have any questions, okay, whatsoever in the session, you can always write it in a chat, and I will be happy to answer that. If you can hear me, please write in the chat. Great. Awesome. All right, great. All right, let's then get started. I see comments from people. Uh, Good to see you guys here. Okay, let's get started. Great. Okay, let's get on with this. Get it done with. Good to see you all here. All right, let's start with pupillary control. So we have a couple things here. We have meiosis and mydriasis. Okay, let's start with pupillary control. We have a couple things here, meiosis and mydriasis. Let's talk about the first thing, meiosis. Meiosis is the constriction. It is the constriction. It is done through parasympathetic, through M3 receptors on which the acetylcholine is going to work. Okay, as compared with, let's just compare first with the mydriasis, which is known as, which is the dilation of the sphincter pupil. And it is done through sympathetic nervous system, which is alpha 1 sympathetic nervous system, alpha 1 receptor. Okay, so let's just take a look at meiosis, first neuron and a second neuron. Let's dive into this picture now to figure out the first and second neuron. So for meiosis, the first neuron is from Adinger Westphal nucleus to the ciliary ganglion via the cranial nerve 3. So let's just take a look at that. From first, we are looking from here from the Adinger Westphal nucleus. Let me zoom in so you can take a look. From here, from this point all the way, it's going to in the ciliary ganglion, which is here, right? And from ciliary ganglion, it's going straight to the sphincter pupillary muscle, here, to the muscle. So second order neuron, so we said this is the first order neuron. The second order is from short ciliary nerve to the sphincter pupillary muscle. So this is the second order neuron. So let's take a look one more time. So this is the first order from this Adinger Westphal nucleus all the way to this ciliary ganglion. That's all first order. And from here all the way towards this sphincter pupillary muscle, the second order neuron. That's exactly what they're saying. So we have a first order neuron, second order neuron. Simple as that. But what do we need to know is, high yield point is that for meiosis, the muscle that is going to constrict is the sphincter pupillary muscle. So here's the mnemonic: short ciliary nerves shorten the pupil diameter. So let me see if I have an image here. So let's just take a look at this image to make sense. You know, this is sphincter pupillary muscle right here, which is a sort of circular muscle, which has an M3 receptor on it. And the contraction of the sphincter muscle will lead to decrease in the size of pupil right here, which is known as meiosis. It is done through parasympathetic because it is the M3 receptor, which is normal, like for example, pilocarpine. But it's also done if you give sympatholytics, which are alpha 2 agonists, or opioids. High yield opioids would also cause meiosis, except meperidine. And this is again, this picture is from general. Okay, just got it from there. So, and the last one is organophosphates. Okay, what we really need to know is just meiosis is decreasing the pupil size is meiosis. It is done through sphincter muscle contraction, because the other one, which is mydriasis, it will be done through radial muscle contraction. Look, both are contracting. That's the thing here. Both are contracting, but one is causing the pupillary size to decrease, and the other is causing the pupillary size to increase because it's the radial muscle on the periphery. So it's going to stretch it up, stretch it open. Normally, you need a direct sympathomimetics that's going to cause it, but other drugs are anticholinergics and indirect sympathomimetics like amphetamines, LSD, meperidine, all of that. Let's get back to our basics that we were talking about, and that is this part. Meiosis and mydriasis. So we got these two neurons. We got the sphincter muscle, sphincter pupillary muscle. Now let's take a look at the mydriasis first, and then we will come back to this pupillary light reflex. So mydriasis, let me just erase this part. Mydriasis, it is the dilation through sympathetic. It has first neuron, second neuron, third neuron. So let's take a look. It is quite long. So let's just take a look at from one side, from one first to all the way third. So start from hypothalamus. Let's just put H here. H is there, so that's the first. Okay, and it goes to where? To the center of budge, which is CA to all the way to T2. So let's say from here, it's going all the way to approximately, let's say T2 from C8, remember? And second order neuron, let's change color. Second order neuron, and why is this important? Because you will see in Horner syndrome, in any point given case here, you can destroy the nerve fibers and it will give you some damage. So second order goes from T1. So let's just say T1 is the main point, the center of budge, right? From here all the way to the superior cervical ganglion. So from here all the way it goes back up top, which is the superior, let me just do it the other way, superior cervical ganglion. It travels along the cervical sympathetic chain near the lung apex and subclavian vessels. Now let's take a look at the third neuron. The third neuron is going from this plexus along the internal carotid through this cavernous sinus, enters the orbit at a long ciliary nerve to pupillary dilator muscle. So all the way from here towards the eye, and to the eye it goes to the pupillary dilator muscle. Sympathetic fibers also innervate smooth muscles of the eyelid, minor retractors, and sweat glands of the forehead. Okay, this is important. Let me read it one more time. So all they're saying is that you have, where did it go here? Third order neuron. Sympathetic fibers also innervate smooth muscles of the eyelid, which are the minor retractors of the eyelid, sweat glands of the forehead and face. And this will come next, what we'll see in Horner syndrome, how it's going to show up. Okay. Now the mnemonic here is the long ciliary nerves, because here these were the long ciliary nerves. They make the pupil diameter longer, right? Longer diameter, meaning wider diameter of the pupil. Shorter diameter of the pupil, meaning decrease the size of pupil. Okay, so keep this in head, and that's pretty much for mydriasis, right? So let's just take a look at now the light pupillary reflex. Pupillary light reflex is light in either retina, send signal via cranial nerve 2. So let's say the light is here. Let's just give an example. We shine the light here. It's going to go from retina. This is retina all the way back there, right on both sides. It's going to go from which nerve? Cranial nerve 2. So this is all cranial nerve 2 to the pretectal nuclei. Okay, look at the pretectal nuclei is right here. Now, if you look here, it's going to the pretectal nuclei and pretectal nuclei, both sides. Now, that one pretectal nuclei will activate bilateral and injure Westphal nuclei. That's important. So let's just take a look at this, what are we saying here. So we are saying that this optic, let's say we have a light. Let me erase this part. We shine light here. Let's just give an example. This goes from this retina all the way from this, from the optic nerve, CN2, all the way goes back and stimulates what? The pretectal nucleus, right? Now, this one pretectal nucleus, if you take a closer look here, it's going to stimulate both sides of Edinger Westphal nuclei. Both sides. Look, this fiber is going here and here. So what's going to happen now is that from this side is going to constrict the pupil, and the other side is also going to constrict the pupil, right? So let's just read this. Bilateral Edinger Westphal nuclei, pupil constrict bilaterally. That's normal. It's called direct and consensual reflex, meaning when you shine the light in one eye, that's direct constriction of the pupil. That's direct reflex, right? But the other eye automatically constricts the pupil. That's called consensual reflex now. Okay. Okay, what is the result of this light reflex? Illumination of one eye results in bilateral pupillary constriction, right? Simple, right? And this is normal, like pupil light reflex, normal reflex. You shine the light in one eye, both of the eyes will constrict. Why? Because pretectal nuclei, this guy innervates both sides of the Edinger Westphal nucleus, and those will cause constriction. Simple. Now we will talk about defects. Now the defect of this is called the relative afferent pupillary defect, which is also known as Marcus Gunn pupil. Here what we have is extent. Let's just read this first. Extent of pupillary constriction differs when the light is shone in one eye at a time due to unilateral or asymmetric lesion of the afferent limb of the pupillary reflex. Example, retina, optic nerve. I'll talk about this, but here let's just read it, the whole thing first. When the light shines into a normal eye, constriction of the ipsilateral eye, direct reflex. So let me just have the eyes here. When we shine the light here, okay, this is the normal eye, let's say. There's the constriction of the pupil here. Simple, right? It is known as the direct reflex. And the contralateral eye, which is the consensual reflex. So this also constricts due to consensual reflex. When light is swung from normal eye to an affected eye. Now this eye was affected. Let me change color to red. This eye was the affected eye. So now when we shine the same light now onto the affected eye, what's going to happen? Now, because we have a problem in the afferent, meaning what is afferent? When you're going towards the brain, when you're taking everything towards the brain, to the nucleus, that's the afferent. Coming in is the afferent, right? So this, something is wrong with the afferent, which they have mentioned. For example, a problem could be in retina, problem could be in optic nerve, could be there. So either we have a retina problem or either we have the optic nerve problem. Something is there. But when we shine the light in the affected eye, this is the affected eye, when we shine the light here, let alone that this would constrict, it will not constrict because it's not getting the signals, because there is a problem in the conduction. And it's not going to let the other guy constrict because the whole connection is out. There is no connection. Exactly what they write here is called when the light is swung from a normal eye to an affected eye, both people dilate instead of constriction. It's the opposite what they're doing. They were supposed to constrict, but when you have a problem, they dilate. That means there is a problem in the afferent limb. Do you think of optic neuritis in multiple sclerosis? Yes. So most common thing, optic neuritis in MS. Okay. And that's about it. So let's just quickly go through this page and move on to the next one. So I think I mean, this is now making sense. So it's pretty easy. So I'll just quickly go through it. So, okay. Here what we have. Simple, simple. So meiosis is all about constriction done through parasympathetic M3 receptor. Okay. First outer neuron, second neuron. First neuron is all about from here all the way to ciliary ganglion. This is first. So from Edinger-Westphal nucleus to ciliary ganglion, and from ciliary ganglion all the way to the sphincter pupillary muscle. That's the second neuron. Important point is short ciliary nerve, which are here terminal nerves that do the job, which is the shortening the pupil. They are the nerves, right? So short ciliary nerves shorten the pupil diameter. For the mid-recess is all about dilation, and all you got to think about is something is coming from hypothalamus all the way to about T1, which is known as the center of budge. From here it goes back upward towards the superior cervical ganglion, and from there it goes towards the eye. And in eye they would innervate the radial muscles. Where are they? Pupillary dilator muscles, which are also okay, and they would dilate the pupil. Okay, and the mnemonic here is long ciliary nerve make the pupil diameter longer. Okay, then we have here the afferent defect. As the name suggests, you have an afferent defect, afferent pupillary defect, meaning either you got the problem in the retina, either you got the problem in the optic nerve. Most common optic nerve problem is the optic neuritis, which is seen in multiple sclerosis, MS. This guy is going to dilate, and this guy doesn't even know it's going to dilate. So that's the problem. That's called the afferent pupillary defect. Something is wrong in the afferent fibers, which are examples, retina and optic nerve. Okay, let's move on to the next page, which is the Horner syndrome. Okay, in Horner syndrome, it's the sympathetic denervation of the face, which will cause ptosis, meiosis, and hydrosis. Triad. Ptosis, meiosis, and hydrosis. Let's take a look at on the left side. So from hypothalamus, we are getting this first neuron that goes all the way from hypothalamus and synapses in the lateral horn. From the lateral horn, the second neuron arises and it travels in the towards the superior cervical ganglion, right? And from superior cervical ganglion, now the third neuron gives and innervates couple of structures. So for us, it's if you look at these nerve fibers, they're going and innervating the forehead sweat gland, the facial sweat gland. So guess what? If you knock out these nerves, you're not going to have the sweat glands in the forehead and the face. So you are going to cause anhidrosis face and of the forehead. But this is not notable much. Ptosis and meiosis are highly notable in a patient, right? So let's take a look at the other one. Then the other fibers, they are going and they are innervating. Look at this muscle. They're innervating the eyelid smooth muscle. When you knock this out, you will not be able to innervate the eyelid smooth muscle. So you can contract. And lastly, look, it's going and it's innervating to the pupillary dilator muscle. What were they doing? They were dilating the pupil, right? They were increasing the pupil size. That is exactly what we talk about in mydriasis. Pupillary dilator muscle increase pupil size. But now when you knock this out, so you are going to get meiosis, which is pupil constriction. Simple. Let's do it one more time quickly. We all know it's ptosis, meiosis, and hydrosis. No, I mean, you know it, I know it, everybody knows it. But here's the thing, how? Because these nerve fibers, when they come out of the superior cervical ganglion and they supply these structures, each structure they supply is going to get knocked out. when each structure is getting knocked out, it's going to cause its effects, which is anhidrosis for these two. For pupillary dilated muscle, you can't do it anymore. It's going to cause meiosis. Eyelid smooth muscle, you can't contract it anymore. It's going to cause ptosis, which is the drooping of the eyelid. Okay, so meiosis, ptosis, meiosis, and anhidrosis. Now, how do we knock them out? What is the cause of the problem? So it is associated with lesion along the sympathetic chain. So this is the sympathetic chain. Along the sympathetic chain, something went wrong. So in the first neuron, due to pontine hemorrhage, lateral medullary syndrome, all of them can knock down your first neuron, which is right here. And it's going to cause all these symptoms again. You could knock out any one of them and cause same thing, right? So let's look at the second one now. Second neuron. Second is stellate ganglion compression, high yield. By the Pancoast tumor, high yield. Pancoast tumor compresses the stellate. I mean, sometimes they mention Pancoast tumor causing compression to cervical ganglion. That's not the case with the Pancoast tumor. Pancoast tumor is going to compress the stellate ganglion. I think it's also in respiratory, I believe. You can also take a look over there. But here, third neuron from the carotid dissection, painful carotid dissection, because it's running against, look, it's circling around where? Internal carotid artery, right? So if you have a carotid dissection, you are going to again knock out your sympathetic innervations, leading to all of this Horner syndrome. It's going to cause everything but anhidrosis is absent. And why is anhidrosis absent? If you take a look, these fibers are already going before they can actually look at this. So if we have aneurysm here or dissection here, you're knocking out your muscles and not the facial sweat gland. So anhidrosis is absent. Okay, so that's pretty much it for Horner syndrome. Let me see if I have anything extra for this. Horner syndrome. So yeah, that's pretty much it. Nothing much. Let's look at the next thing, which is called ocular motility. Okay, simple. No rocket science about it. All we gotta know is this mnemonic, which is LR6 SO4R3. Lateral rectus by CN6. SO4 superior oblique by CN4. And R3 means the rest of the muscle by third cranial nerve, CN3. So that's what they mention here, the same thing as I just said. Okay, taking a look at this image, let's take a look, where are they present? Okay, so lateral rectus is on the lateral side, medial rectus on the medial side, superior rectus, superior side, inferior rectus, inferior side. The two new muscles, not new, but two other muscles which are not to their names, which is one is inferior oblique and superior oblique. One important thing for superior oblique, there is a pulley mechanism on the superior oblique through the trochlea. So it goes through the trochlea and then gets on attached to the eyeball. So taking a look at this here, it's going to make things easy. Okay, look at superior oblique. It starts here, goes through this trochlea, and then goes back. Okay, and inferior oblique is going the other way. Okay, now, so let's just read this. Arrows in illustration depicts direction of the gaze, which to test each muscle. Obliques go opposite. Okay, that's a very good one. Obliques go opposite. So superior oblique and inferior oblique tested with patient looking right. Okay, IOU, inferior oblique tested looking up. So these are tests that you can do in order to figure out which muscle is out. But more important here is this blowout fracture. Simple but important. Is the orbital floor fracture, usually due to trauma to an eyeball, or infraorbital rim. Taking a look at this picture. So this is eyeball. So normally you should have this this bone being fully. There shouldn't be any opening here, right? So since there is an opening here, it's orbital floor fracture. So you can see this is the floor of the orbit. There's a fracture. That's why there is orbital structures are coming out of it, right? So here. And why? Question is, why would it happen? High yield trauma. Trauma to the eyeball. Punch. Eyeball. Punching on the eyeball. There was a fight. Somebody punched someone. Here you go. They, they are going to present with diplopia and something, and you take a look on imaging, you find, okay, wow, there is a blowout fracture because of the orbital floor fracture. Because why? Because this is the very it is prone to fracture. This lower part prone to fracture. Okay, increased risk of IR muscles and or orbital fat entrapment. So inferior rectus can entrap in this, as inferior rectus is at the very bottom here, so it can entrap. And or orbital fat can also be entrapped here. May lead to infraorbital nerve injury also. Okay. And this is a very high yield image. Okay. Now the next thing is called strabismus. Strabismus is all about misalignment. It is a deviation of the eye towards the nose, astropia, which is known as astropia. So here's the eye, here's the nose. Now when you deviate the eye towards the nose, it's called esotropia. Is the most common type of strabismus in children. Complications include amblyopia. I hope I'm saying it right. Amblyopia, yeah. Diplopia and adverse psychosocial impact. First, let's talk about amblyopia. Amblyopia is the lazy eye, meaning decreased visual acuity due to maldevelopment of the visual cortex. So you have a maldeveloped visual cortex that's going to cause decrease in visual acuity, caused by abnormal visual experience early in life due to strabismus. So strabismus complication is amblyopia, which is lazy eye. Typically unilateral, only one side is affected. Okay, so let's just recall this strabismus again. It is the misalignment in children. If you see something in a child, one eye is misaligned, it is deviated towards the nose. Okay, and that's strabismus. But it could complicate into amblyopia, which is that side would not even develop because it was a child, right? So it wouldn't develop. That's just going to decrease visual acuity. Okay. Diplopia, double visioning, and because they're going to look pretty, they won't look good, so they will have a psychosocial impact as well. Because they will have some psychosocial impact because how they look, right? So this is strabismus and amblyopia. Okay, quickly going through this page again. We got the Horner syndrome, pretty simple thing. Horner, ptosis, meiosis, anhidrosis. Let me zoom in. Okay. Knocking out these structures are going to give you all of that. And it is due to stellate. Important thing is stellate ganglion compression by Pancoast tumor and carotid dissection. Okay. Ocular motility, LR6, SO4, R3. Blowout fracture is all about fracture to the eyeball or trauma to the eyeball, causing this inferior rim to fracture because it is prone to fracture, causing IR, inferior rectus entrapment, because IR is at the very bottom, right? Okay, so that's what we have with this blowout fracture. Then we have strabismus. Is going to be misalignment of the eye, which is the crossed eye, for example. Deviation of the eye towards the nose. Esotropia is most common type, and it can cause amblyopia, which is maldevelopment of the visual cortex causing decrease in visual acuity, okay, diplopia, double vision, and adverse psychosocial impact. Okay, that's pretty much all. Moving on to the next is the cranial nerve. Cranial nerve 3, 4, and 6 palsies. Okay, here all we have is, let's talk about the first one, which is the CN3 palsy. It's the oculomotor nerve. Oculomotor nerve. Now, important thing about oculomotor nerve, which is high yield, is that it has a central part and a peripheral part. Central part, it is the motor part, and the peripheral part is the parasympathetic outflow path. Okay, so let's just read it, and I will explain anything that comes up here. So CN3 has both motor, which is central again, and parasympathetic, which is periphery components. Common causes include, so CN3 damage common causes include ischemia. Ischemia leads to pupil sparing because the motor fibers are affected more than the parasympathetic fibers. And that's high yield. And it will come up, and we will talk about that in just right now. But here, the second part is uncal herniations lead to coma, PCOM, posterior communicating artery, aneurysm, that's again in a moment, is a sudden onset headache. Okay, cavernous sinus thrombosis, it leads to proptosis, involvement of CN cranial nerves 4 and 5, V1, V2, and 6. And that's, we will see that in cavernous sinus. Midbrain stroke leads to contralateral hemiplegia. Now is the important part, that the central part, it is the motor part, it sends the outflow to the, because it's a motor, so guess what motor thing are we looking at in the eye? All the extraocular muscles, right? Muscles of the eye are the motor things. So the central part supplies the ocular muscles, extraocular muscles. So if you affect the central part, if you knock this out, what's going to happen, which, I mean, you knock it out where and when? You knock it out in any ischemia, vascular disease. For example, in diabetes, where you have the glucose that just goes and forms sorbitols, leading to ischemia, leading to damage to the nerve, the central part of the nerve, and also due to decreased diffusion of oxygen and nutrition to the interior, which is the middle part, from compromised vasculature that resides on the outside of nerve. Now, important thing is, if you knock this out, what is that? So you got the whole idea, but now the important point is, if you knock the middle part, which is the motor, so middle motor, right? If you knock it out, you're going to have ptosis and down and out gaze of the eye. Let's take a look at here. So you have ptosis, because remember, the motor part was supplying to the extraocular muscles. So when you knock out the muscles, you are going to get this ptosis. Not only ptosis, but also down and out gaze of the eye. Okay. But high yield point that you have to remember is the ptosis. Why is the ptosis? I'm going to talk about the other one now, which is the periphery, which is the parasympathetic. So periphery P for parasympathetic outflow. If you recall just back right now, we talked about meiosis was done through, meiosis is the construction of pupil, is done through parasympathetic nervous system, right? So if you knock out this periphery, which is the parasympathetic fibers, what you can do is now you will not be able to constrict the pupil. So you are classically going to see a blown pupil. So let's read this now. Parasympathetic output leads to fibers on the periphery are first affected by compression. Okay, you could, if there is a compression like PCOM, posterior communicating artery aneurysm, is going to compress which structure first if there is a PCOM here? Well, it's going to compress the periphery, right? And that is going to that is going to cause the damage to the parasympathetic outflow, and it will lead to diminished or absent pupillary light reflex. That's one thing. All right. Second thing is blown pupil, which is just dilation of the pupil, because now you can't constrict it. Now recall who was constricting this pupil. Well, the constriction was done through parasympathetic